story starts at 4 o'clock while I was on my trauma rotation, which for us is in Miami, where cars go faster and people are a lot more tan. So it was 4:05, I call in, ETA 5 minutes, guy was struck by a car. And you know, in Miami, cars go faster than Manhattan, so pedestrian struck can be very sick. So we knew that going in. We're working in a trauma bay, EMS comes in, GCS is 3, they wheel him over, they get him on the stretcher, I do my fast, because that's my job, and this is what I see. And so, because it's a little bit grainy when it gets this big, there's the radiology sign, there's black stuff between the kidney and the liver. So yay, we found something on the fast. I looked up at the monitor, this is what we had, and this is a place where, when I put those two things together, this guy needed to go to the OR. So they didn't go to the CAT scan, it wasn't pass go. In case you didn't know, these are unstable vitals. So, just to wrap things up, he went to the OR. So I went back to my desk, where I tried to prevent interruptions by looking busy. And then about 30 minutes later, the attending surgeon wheels the patient by to the CAT scan. So this doesn't happen very often. For those of you that have worked with surgeons, the attendings don't tend to wheel them. But he also has the senior trauma fellow, the junior trauma fellow, and another surgeon with him. So I followed because it seemed interesting. And this is what we got in the CAT scan. So this guy wasn't, when they opened him up, they didn't find much in his belly. Nothing that was going to explain what was going on with his vitals. What we saw on CT was that this is C1, way up here, still attached to the skull. C2 is down here. In case you didn't know, they're supposed to be beside each other, like on the top. This is blood, extra on both sides. And here you can see on the lateral view. And it wasn't that obvious from the outside that this guy had internally decapitated himself. So what I wanted to talk to you about was neurogenic shock. You don't see it all that often. It tends to come in these traumas. And what you need to know about neurogenic shock is it's this combination of hypotension and bradycardia that you see in high C-spine injuries or high thoracic injuries. But it's because of this loss in sympathetic tone. So the problem is they've lost their entire sympathetic system because of the injury, and that's why you're seeing vitals that are not in range with what you would expect for this patient otherwise. Now, for our patient, he met criteria pretty easily. He had this low blood pressure and he had this bradycardia. Now, trauma can also do this. And the problem with your neurogenic shock is you're going to often have this in a multi-polytrauma issue where you don't know how much of this is hemorrhagic, how much of this is something else that's going on. So the literature states a bunch of different versions of what these numbers should be for neurogenic shock. And so what it really comes down to is it's a relative bradycardia, and the more recent studies are looking at even higher numbers, less than 80 beats per minute in these patients, and a relative hypotension or a systolic under 100. This may be in the same setting as hemorrhagic shock. What you'll see, the incidence for these patients is it's fairly common if they have a high C-spine, high thoracic injury, somewhere between 14 and 44%. The problem is, again, hard to define issue, but you're going to see it in these patients. The hypotension is really what you can treat. So this is the problem that you as an ED physician can do something about. And what you want is a goal map somewhere between 85 and 90, because that's what will perfuse the spine they have left. So if you want to save what's there and what is still in the spinal cord, you need a little bit higher than you would initially assume. So how do you do that? Blood, yes. If there's a hemorrhagic component, you should give them blood. But for some of these patients, for our patient, it wasn't blood that he needed. Well, we couldn't do anything for mine. But for your patient that may have an injury they could survive from, pressors are an option. There are really no contraindications to any of them. Most of the neurosurgeons like norepi. It's alpha, it's beta, we use it for sepsis, we're comfortable with it. It's a good first-line pressor. So at the end of the day, we delayed this guy's diagnosis in part because he went to the OR with his C-collar on. We thought he was unstable and he needed to get to the OR. Nobody took the whole C-collar off and looked underneath it. Probably a good thing to do. So I want to leave you with just a couple pearls about it. One, be wary of relative bradycardia in trauma patients. something bad could be going on. They could be ready to code, or they could have a high injury in their spine. Norepi is a good pressor. In case you didn't know from sepsis, it's also good in other things. And always look under the C collar. C collars are not a benign intervention. Thank you.